Yes, sir.
Now, you know the sharing options and all, no?
Yes, sir. I'll share now.
Keep the PPT open first.
Yes, sir.
You have done it in the hospital, so you can do it.
Yes, sir.
Good evening, sir. Dr. Rajiv, sir. Namaskara. And
Good evening,
Hitesh sir also has joined. Good evening, Dr. Saravanan, sir.
Good evening, sir.
Everyone.
Namaskar.
Everyone.
Hitesh sir, good evening, sir.
Good evening, very good evening, sir.
Swapnil, are you okay, ma?
Yes, sir.
Dr. Hitesh has got
I
friends in
told him.
Sir?
Dr.
I
Hitesh?
told him not. I told him all examiners are there to teach you rather than they will ask some questions. If you would say don't, they brought COVID and 2 years back when they joined July 2020. So
Actually, teaching is the best way of learning.
Yes, it is.
we have to reassure these people. Their presentation chances were also less that last 2 years. And so what happened, man? Swapnil,
I'll start, sir.
Yes, you can share.
We are not seeing, no. First you open your share screen, give an option of that and make it slideshow.
Yes, sir.
Yes.
Make the, very good, ma. Very good. Just run through the slides, Swapnil.
Yes, sir.
Just go through. Run the slide.
Yes.
Go ahead. Go ahead. Very good.
Okay. Okay. Till the end, Swapnil.
Yes, sir.
I'll be keeping quiet, sir. All of you, please
Are you sure, sir? Sure, sir. I understand.
look after.
Yes, sir.
Yeah.
Swapnil,
Yeah.
we are unable to see your video, ma. We are able to see Shanai sir's video.
Sir, I'm sharing my screen actually.
Okay,
So,
okay, okay. Now it is okay. Now you try showing your PowerPoint.
Yes. Yes, sir.
You share your PowerPoint. If you share the screen, this problem will come. Come out a bit. Come out.
Okay, sir. Just a minute.
You share only your PowerPoint.
Yes, sir. Is this better, sir?
Very good. Very good.
Perfect, ma. You're doing good. Just hold it for a few minutes. I think Kanna sir is joining. Sir, good evening, sir. Kanna sir. Ajay Kanna sir, good evening. Okay, I think he is.
Dr. Swapnil, there is usually a small gap between when you are asked a question and you answering. Okay.
Okay.
Similarly, you just give a little wait for someone to complete question. Okay.
Yeah.
If you
Okay. Sir, can we start, sir?
Pardon, please repeat. Yes, thank you. Sir. Thank you.
Okay. So, good evening, friends. We are happy to have you on board for yet another postgraduate clinics of all Fridays. And we have two important case presentations. One on peripheral arterial disease to be done by Dr. Swapnil. He has been kindly contributed by Professor Shanai sir from KMC Manipal. And the other case is kindly contributed by Professor Kanna sir and Seema Kanna ma'am. And Dr. Shubham Gupta is going to talk about carcinoma of the penis. So we have four invited faculties. Professor Saravanan sir from Madurai Medical College. And we have the other faculties are going to join us. Professor Sujata Patwardhan madam will be joining us shortly. Dr. Harinder Bedi is Harinder Singh sir is just finishing his surgery, so he should be joining us soon. And we have Srinivas Nukala sir also joining us shortly. So anyway, it is time, and we will start the presentation. I request the faculty to take over. Good luck, Dr. Swapnil. All the best.
Thank you, sir. A very good evening to all. I'll be presenting a case today. My guide is Dr. Rajgopal Shenoy sir, and my co-guide Dr. Bharat sir. And thanks to our HOD, Dr. Dinesh sir, from KMC Manipal. Today, I'll be presenting a case of a 58-year-old gentleman, a chronic smoker, and a manual laborer by occupation, hailing from Chitradurga. He presented with the chief complaint of pain in the left leg since about 6 months, and blackish discoloration of the medial foretoes since the past 1 month, and a blackish patch over the dorsum of the foot since the past 2 weeks. The patient was apparently all right about 6 months ago when he started experiencing pain in the distal left foot, which appeared on walking or activity and was relieved after rest. The pain was gradually progressive to involve the entire left foot and the distal half of the left leg. This was aggravated by walking and on lying down, and relieved by rest or by hanging the leg by the side of his bed and by pressing the foot. Currently, the patient has pain at rest since the past 1 month. He noticed a blackish discoloration of the tip of his second toe about 1 month ago. This was insidious in onset and gradually progressed to involve the entire second toe up to the proximal phalanx and the first, third, and fourth toes. This was followed by swelling of the left foot since the past 2 weeks and a black patch over the dorsum of the foot. This patch he attributes to friction by his footwear. There is no history of trauma to the limb, no history of similar complaints in the contralateral limb or either of the upper limbs. There is no history of chest pain or breathlessness, headache, focal limb weakness, deviation of angle of mouth, no history of blurred vision or blackouts, no history of abdominal pain or impotence, or color change of fingers on exposure to cold. The patient is not a known diabetic or hypertensive or asthmatic, and there is no history of ischemic heart disease or cerebrovascular events in the past. There is no history of surgeries in the past as well. The patient is a known smoker since the past 25 years and smokes about 24 BDs per day and occasionally cigarettes. And he also consumes about 180 milliliters of hard liquor per day. His appetite is currently reduced and sleep is disturbed due to pain. Bowel and bladder habits are regular, and there is no family history of similar complaints. To summarize the history, we have a case of a 58-year-old chronic smoker, nil premorbid, presented with pain and blackish discoloration of the medial foretoes since the past 1 month. At the end of history, I would like to suggest a diagnosis of peripheral arterial occlusive disease, probably due to Broca's disease.
Swapnil, can I intervene
Yes, sir.
at this point of time?
Do.
Swapnil?
Yes, sir.
Yes. The main complaint started with type of pain, pain in the leg.
Yes, sir.
Pain is in the foot, followed by pain in the distal leg. Okay.
Yes, sir.
Okay. That indicates what? What type of pain you have to evaluate, right?
Yes, sir.
Can you able to evaluate the type of pain? What are various types of pain? There is vascular
Yes.
pain, among vascular, arterial, venous, neurological
Yes.
pain, arthritic pain, musculoskeletal pain. There are so many issues. Okay.
Yes.
Among this, which you consider one? What type of pain this one?
So the patient complained of a cramping kind of pain, claudication pain.
Along with the pain, other changes in the toes and limbs, we can
Yes.
assume to be a vascular origin. Okay.
Yes, sir.
In that case, it is arterial disease. Or do you like to evaluate the type of pain, whether it's a claudication pain or cramping pain Like that, have you evaluated? You're not
Yes.
told anything about that.
Yes, sir.
Nature of pain. Nature of pain.
Yes, sir. I asked the patient what was the nature of pain. He said it was kind of a cramping pain that started on activity, more in the toes. And
Cramping, you can still more say clinch. Claudication. Is it claudication or not?
Yes, sir. It is cramping, aching kind of pain.
Which is continuous pain or related by something, aggravating factor, relieving factor, all those things you have to say. Okay.
Yes, sir.
Yeah, claudication distance also. Suppose you say pain during exercise or walking, the relieving factor, claudication
Yes.
distance, because he ended up in rest pain. Okay.
Yes, sir.
Along the course of the pain development, you have to ask any history of claudication distance.
Yes, sir.
That's not important in history, personal illness. Okay.
Yes, sir.
Okay, then.
Okay, so
And you asked history of trauma. Why you asked for history of trauma?
So history of trauma, because if there is in this case, I'm not suspecting it to be a acute limb ischemia, but trauma induced acute vascular injury can also lead to blackening and gangrenous changes in the toes.
So it is not an acute ischemic limb. Okay.
Yes, sir.
Even then, trauma can produce what are vascular changes that can produce trauma. Suppose we artery and vein nearby, trauma happens. What happen? What may happen?
So it can lead to arteriovenous malformation.
Yes, very good, very good. In the past history, you are asked so many things, but you are not asked about any drug history or treatment history, because the patient is suffering for 4 to 6 months duration ailment.
Yes,
Any
sir.
type of treatment that relieves the pain, any manipulation, like that you might have asked and enumerated in the history. Okay.
Okay, sir.
And smoking, you are told the number of years is what is the smoking index, and it is significant or not. That also you have to enumerate.
Okay, sir.
Okay. At the end, you have summarized the history of present illness, past illness. You have come to a conclusion of Bujo's disease. Is there any
Yes.
point clinching towards Bujo's disease in the history itself? You can
So in the
say
history-
peripheral vascular occlusive disease. You should not pinpoint the etiology. Okay. It's a condition of peripheral arterial occlusive disease. That's all. From the history you derived. You cannot say Bujo's disease, or you can say any point towards Bujo's disease at this stage.
So he has this 25 years
Only
history of
smoking history is there. Age group also, older age group, not middle age group. Okay.
Yes.
So in that conditions, you need not pinpoint towards Bujo's disease at this stage. Okay.
Yes.
Yes, you can proceed.
Yes.
Swapnil,
Yes, sir.
I'd like to ask you a few questions. Swapnil, this is Dr. Sai.
Yes, sir.
Swapnil, you said that he gets relieved by pressing his foot. Why do you
Yes,
think it gets relieved by pressing his foot?
Sorry, sir, I couldn't understand the later end of your question.
Sir, your voice is interrupted. You can switch off video, then it will be better perhaps.
Sir is asking you, why does this pain reduced while hanging down and pressing the foot? Show
Yes,
that
sir.
slide, show that slide, relieving
Yes.
factor. Just show that slide.
Yes, sir.
Yeah. So sir is asking you this question. Please
Yes, sir.
answer. That is Dr. Raji Sahai. Okay. Yes.
Yes, sir. On hanging the foot by the side of the bed, there is increased blood flow in the limb because of the gravitational effect. And by pressing the foot, the patient is actually trying to push the blood into the distal end and kind of momentarily relieves the pain.
No. So it doesn't push the blood. How can you push the blood by just grabbing your foot? Can you?
No, sir.
What he's doing is that the palm is warm. So he's keeping his foot warm.
Yes, sir.
And that is causing vasodilatation. Okay.
Okay, sir.
You've not spoken anything about his social history, his family history. How is he married? Does he have children?
Yes, sir.
Right, all that has to come.
Okay.
Okay, medication like
Hello.
Yes, sir.
Hello. Yeah. Say in the same slide.
you asked about the sensation of the foot. Are the sensations intact in the foot? How do you
Yes,
ask?
he's able to distinguish hot and cold.
So that should come out in his history. How do you
Yes.
ask for sensation?
Sir, I asked if he was able to understand if he's walking on a hot ground or
Okay, a simpler way is that whether his chappals come out of his leg, of his foot while walking.
yes, sir.
Okay. About claudication, he's having rest pain. Do you think claudication distance is important here?
Claudication distance, sir, he had a claudication distance of about 100 meters about 2 months ago. And since then it has been worsening and he has not been able to walk without severe pain.
Okay, you've diagnosed this as probably Berger's.
Yes, sir.
Swapnil, can you hear me? Hello?
Yes,
Hello?
yes, sir. I can hear you.
You've diagnosed it as Berger's disease, right? What is Shinoya criteria for Berger's?
Shinoya criteria is, sir, tobacco use, as in smoking history, then age less than 45 years, and more the distal limb is more affected than the proximal limb, and absence of comorbid conditions, diabetes or hypertension.
Yeah, atherosclerotic risk other than smoking.
Yes.
Right. So in your patient, what is all the 5 criteria have to be there?
Yes, sir.
So what is missing here now? Do you think it's still Berger's?
No, sir. Because the patient's first, the age is 58, and second.
Okay, Swapnil, don't change your diagnosis just because I have challenged it, right? Don't get cowed down by my saying why that is not. You've written Berger's. Prove it to me that is Berger's. Don't get cowed down because I said something. Okay?
Yeah.
That's a good student. So you tell me, why do you think it's Berger's? You still think it's Berger's?
So points in favor of Berger's are the smoking history, then absence of any risk factors that cause atherosclerosis. He's not a non-diabetic, or there's no history of known hyperlipidemia or family history of hyperlipidemia. And this is more involving the distal limb.
Okay. Swapnil, I would have been happier because you can't know whether he's got diabetes or not. You've not tested him, right?
Yes.
There's so many times people are just diagnosed diabetic as first time they come. And about atherosclerotic risk, other
computer
is not there.
audio on பண்ணாம phone call on பண்ணாம இன்னொரு ஆப்ஷன்ல இருக்கு.
You just say that I think it could be Berger's, but will require further investigation. That would be a right answer. Okay.
Sure, sir.
You want to continue, sir? Anyone, please?
Swapnil.
Okay, continue.
Swapnil.
Yes,
This is Dr.
So you're muted.
Sir, you are muted, sir. Please unmute, sir.
Yes,
Yes.
sir. Yes, sir. So you're given a history that aggravated by walking and lying down. So both walking and lying down also it aggravates the pain, or what?
Yes, sir. On walking, because of the ischemic.
आज की नहीं, क्योंकि हमको ओटी बोलना पड़ता है ना, हमको पहले बताओ, इससे लास्ट मोमेंट नहीं भर्ती होंगे करें.
Hello, sir.
हाँ, खाना भी हल्का खा ले. देखो मेरा बात सुनो, वो भर्ती हो रहे हैं नहीं हो रहे हैं, क्योंकि हमको एनेस्थेटिस्ट को बोलना, हमको कोई बताया नहीं ना, एनेस्थेटिस्ट को बताना होगा तो ओटी तो बताना पड़ता है ना.
Swapnil, now you answer Dr. Srinivas' questions.
Yes, sir. So the patient has pain on walking, which is due to the ischemia of the muscles. And the patient also has pain on lying down because anti-gravity, already the blood supply to the limb is compromised. And in lying down position, there is even further reduction in the blood supply. So that's why he has pain on.
So lying down doesn't come under taking rest.
No,
Don't
sir.
you-
Rest specifically means that the patient stops walking or.
No, when the patient is walking down and lying down, doesn't come under the rest or not. I think the
But-
framing of the sentence itself is wrong, I think. So you want to convey that the patient is having rest pain, isn't it?
I
Yes, sir.
think correct, sir.
Better you
Yes.
you
Framing
should
that.
have directly written like that. Patient had rest pain, isn't it?
Okay.
Yeah.
Sure.
As sir told, the another point I want to add is that by pressing the foot, what he tries to do is he is also trying to decrease the venous blood flow. So once it is decreased, so the total contact period of the blood to the tissues will be increased. So the pressure gradient between artery and veins will be decreased.
Yes, sir.
So that increases the total contact period of the blood to the tissues. So that
Yes.
improves the pain, isn't it? That's what he's trying to do, both in hanging the leg by the side of the bed and also by pressing the foot.
Yes.
Hanging the leg by the side of the bed also decreases the venous return, isn't it?
Yes, sir.
So he's trying to decrease the venous return because the arterial supply is already poorer.
Yes, sir.
Yeah. Okay, proceed.
Yes. I'll proceed to the examination, sir. On general physical examination, the patient was conscious, cooperative, and oriented to time, place, and person. A pulse of 82 beats per minute was recorded in the right radial artery, which was regular and normal volume. No arterial thickening was appreciated. The detailed examination of other peripheral pulses I have elaborated subsequently. A blood pressure of 118 by 90 millimeters of mercury was noted in the right brachial artery in sitting position, and a respiratory rate of 15 cycles per minute was recorded. The patient was afebrile at examination. There is no cyanosis, clubbing, or icterus noted, or pallor, or lymphadenopathy. A non-pitting edema of the left foot was seen up to the ankle. Clubbing and onycholysis was noted on both the fingernails as well as the toenails. There is no arcus senilis or xanthelisma noted. On locoregional examination on inspection, the second toe was black and shriveled up to the proximal phalanx, and a line of demarcation was noted. First, third, and fourth toe tips were blackened and not well demarcated. A black patch of about 2 into 1 centimeter was seen around the dorsum of the left foot, with surrounding erythema and some pus discharge. The patient was in sitting position with the left leg flexed at the hip and the knee, and the patient was clutching the left foot. Loss of hair was noted up to the distal third of the leg, and muscle wasting was seen at the calf. On palpation, the foot is tender. The left leg was cold up to the knee, and non-pitting edema of the left foot was there. There was no palpable crepitus. On sensory examination, the temperature sensation was preserved and crude touch sensation was preserved. Vibration sensation was not appreciated, and fine touch was also not appreciated. On peripheral pulse examination, in the right lower limb, dorsalis pedis, anterior tibial, posterior tibial, and popliteal were all palpable, and femoral pulse was felt, and there was a thrill felt. In the left lower limb, the dorsalis pedis, anterior tibial, posterior tibial, and popliteal were not palpable, and femoral pulse was feeble. In the upper limb, Bilaterally radial, brachial, axillary, and subclavian pulsations were palpable, and bilateral common carotid and superficial temporal pulsations were also palpable. On auscultation of the femoral artery, bruit was heard, and at the abdominal aorta also a bruit was heard. However, no bruit was appreciated at the common carotid arteries. On systemic examination, cardiovascular system, first and second heart sounds were audible. There were no murmurs heard. CNS, there was no focal neurological deficit or no cranial nerve weakness. Sensory examination, as I have mentioned already in the local examination, sir. Respiratory system, bilateral normal vesicular breath sounds were heard or any bowel sounds audible. At the end of history and physical examination, left lower limb peripheral arterial occlusive disease in critical limb ischemia at present, involving the femoropopliteal segment, likely due to Berger's disease.
Swapnil,
Yes.
hello. You had told non-pitting edema.
Yes.
Is there any significance? There is edema. Definitely there is edema. Why do you want to say non-pitting edema? Usually non-pitting edema when it occurs, in acute condition or chronic conditions?
Generally, acute condition.
Acute condition. Acute condition, acute vascular obstruction could is only pitting type of edema. Only lymphedema will cause non-pitting type of edema. That deliberately something should be there while committing. If you want to say non-pitting edema, you have to correlate why it happens. Okay. We are told black patch, no? There is no terminology. There is no medical terminology of black patch. You have to say diagnosis. What type of changes happen to the skin? Okay, that patch is skin. The patch is change of the skin. That's all.
Yes.
Okay. What type of change of the skin you have to mention, whether it's a wound or it's a gangrene.
Yes.
Okay. Then crepitus, you are told. There is no crepitus. What are conditions that will produce crepitus?
So crepitus can be appreciated if in case of a wet gangrene or gas gangrene. Then there is.
Okay. And in the provisional diagnosis, you are concentrated only on the, for diagnosis, you are concentrated only on the left lower limb. You are told some finding in the right lower limb also. Okay.
Yes, sir.
At the femoral region, you have felt some thrill.
Thrills.
That also has to be correlated in the provisional diagnosis at the time of this local examination. That also some changes happened in the right lower limb also. You need not finish. Okay, it needs further evaluation, investigations. So in the provisional diagnosis, this also has to be accumulated. Changes in the right lower limb. That is some thrill you have felt. Okay.
Yes.
Okay, Swapnil, there's some which I want to point.
Yeah, one few things.
Right.
Okay, sir. Okay, sir. Go ahead, sir.
Yeah, Swapnil.
Yes. Sir.
What you've missed is that was there any foul smell?
No, sir. There was no foul smell.
So this has to be mentioned. Why is it important?
So foul smell typically indicates a wet gangrene.
Right. So whether there's foul smell. Have you mentioned about the lymph nodes in the inguinal region or the popliteal region?
No, sir.
That you've missed. Joint movement, limb length.
Yes.
Have you tested for the joint range of movement in each joint in the lower limb?
I have examined for joint movement, sir.
But you've not mentioned.
I have not mentioned it.
So all this is they are grossly missing.
Yes.
What about positional sense of the joint? Joint position sensation sense.
Joint position sensation I have not examined.
Right. How do you do that?
So we tell the patient to first we have to make sure that the patient appreciates joint sensation in the uninvolved limb, and in this limb we'll try to move the joint passively, flex the foot passively, and tell the patient to keep the other foot in the same position, same degree of flexion,
No, I think you know you don't have an. You have the great toe, so you tell the patient that when the toe is up, right?
Yes, sir.
Whether in the sign is down, then you ask him to close his eyes and move the toe up and down and leave it at a position and ask him at what position is the great toe.
Yes,
That's
sir.
how you test for it. Okay, please, sir.
Swapnil, one thing, sir, go back to your auscultation part.
Yes, sir.
First, general examination part, you said that the toenails they have clubbing and anecholysis. What is meant by clubbing there?
So there is clubbing observed in the fingernails, sir.
Clubbing of the fingernail.
Yes.
So do you find a clubbing in case of a peripheral vascular disease?
Sorry, sir.
Do you find clubbing in peripheral vascular disease?
No, sir.
In fact, they'll be shriveled, no?
Yes, sir.
Clubbing is a wrong word there,
Yes, sir.
isn't it?
Yes,
So
sir.
another thing is that, so during the auscultation part, you said there is bruit both in the abdominal aorta as well as the femoral artery.
Yes, sir.
Is it possible? So where do you get a bruit?
The bruit is indicative of a turbulent blood flow, sir. So across atherosclerotic vessel or a thrombosed vessel.
Do you find it proximal to the occlusion or distal to occlusion?
Distal to the occlusion, sir.
No. Always proximal to the occlusion.
Okay, sir.
So once you have bruit in the abdominal aorta, that means that the abdominal aorta is already having an occlusion. How can you have a bruit at the femoral artery?
Yes, sir.
I think either of them should be wrong.
Yes, sir.
Okay. Now you can proceed. You said the critical limb ischemia. Yes.
Yes, sir.
Okay. Okay. Proceed.
What is the age of your patient?
58-year-old, sir.
Okay, so in 58 years patient where you are getting a bruit in the femoral artery and you are keeping the possibility of Burgess disease.
So atherosclerosis is also likeliness, sir.
Hmm?
Second provisional is differential diagnosis atherosclerosis, sir, because of the.
So will you like to change the order or will you like to still stick with the Burgess as the first diagnosis?
Sir, I would like to stick with Burgess disease because in the other limb, although there is thrill, palpable and audible bruit, there is no involvement in the other limb.
You want to say that Burgess will only involve all the four limbs or only the atherosclerosis will involve all the four limbs? You want to say that?
No, sir.
And you know, you have described your pulses only present or absent. There's nothing like the present or absent. There
Yes,
is
sir.
always a grading of that. You know, what
Yes,
is the
sir.
normal pulse volume? How much is the normal pulse volume? How do you write that?
So generally we write it as 2 plus, sir. 1 plus to 2 plus.
So 1 plus is weak.
Yes.
So 2 plus is normal.
Yes, sir.
So if you want to give, so there's nothing like the present or absent. You have to tell about that.
Yes,
All the
sir.
pulses, you know, whether it is 1 plus or 2 plus or minus or 3 plus, then only one can understand about that.
Yes, sir.
Okay.
Swapnil, what could be the cause of?
Swapnil, it is unusual to make a diagnosis of the Burgess. I think if you are putting that as a first diagnosis at the age of 58 with the comorbidities, I think nobody will be accepting because the resolution duration is not there. So please do not make Burgess disease as a diagnosis. That too, you are thinking that its aorta is involved, femoral palpable is involved, and that kind of thing. There is a criteria. What are the criteria to say Buzzard's disease?
Yes, sir. Shioneville's criteria.
What are the criteria?
So tobacco use, that is cigarette smoking.
Yeah.
And
Okay.
age less than 45 years. More
So
distal.
age less than 45.
50 years.
Limb. There should not be any comorbidities. And when
Yes,
the
sir.
patient has a comorbidity, we will not be able to think in terms of that. So, but clubbing may not be the feature of ischemia, but a person who is smoking continuously, having a clubbing, what do you think the possibility could be?
So he could be a chronic obstructive pulmonary disease, case of.
Yes. Other than that, a chronic smoker comes with you, the clubbing, you should always think in terms of any carcinoma with the lung, anything with the additional effect. So always remember, a patient comes with a peripheral vascular disease can have other problem also. So this is a telltale sign. You should look into that also.
Yes, sir.
Swapnil, a couple of points which I wanted to ask you.
Yes,
Did
sir.
you ask for and look for Raynaud's phenomena?
Yes, sir. I had asked during history if there are any color changes observed.
It was not mentioned. Was it mentioned? I missed.
Yes, sir.
Okay. And what about his gait? Have you seen his gait?
Yes, sir. He walks with a limp, sir. The left foot is involved.
Does he need any crutch or something?
No, sir. He walks without support, but there is antalgic gait, sir.
You are telling about the claudication. So what are the types of claudication you know?
Sir, types of claudication are arterial claudication, venous claudication, and neurogenic claudication.
So what is the venous claudication?
Venous claudication, sir, it is classically seen when after a history of long-term standing, and it is not relieved as fast as an arterial claudication. It takes more time to relieve.
And elevation of the limb.
Elevation of the limb will also help in relieving the pain.
Relieving the pain. So what is neurogenic claudication then?
So neurogenic claudication, sir, it is not incited by any particular event. It is generally due to entrapment of nerves and sciatica kind of pain, and it may be relieved by certain positional changes.
Yes.
So called as a claudication or pseudo claudication?
Pseudo
claudication.
It is not called as a claudication. This is pseudo. Why it is called pseudo claudication?
Sir, there is no
claudication pain. No. Claudication, there should not be any pain at rest.
Yes.
If there is a pain at rest, it cannot be a claudication pain. So
yes.
Pseudo claudication, because neurogenic, it has the symptoms, it is relieved, but it is not due to, in the rest also the patient will have. When he is standing, everything will be there. That is why it is termed as a pseudo claudication.
Yes.
How did you test for the temperature of the limb?
Temperature of the limb, sir, first with the dorsum of the examiner's hand, we test for the normal limb or the uninvolved limb, and then we compare with the limb being examined.
But how do you, so if you have to, like, the lower limb is there, so will you start from the thigh or will you start from the foot?
Sir, I will start from the foot, sir. Because in this case, particularly, we want to know the transition point where the point where the limb is cold and where the limb is warm.
So we start palpating by?
From distal to proximal.
Okay, and how will you palpate that?
So with the dorsum of the fingers, examiner's palpating fingers.
Okay. Did you palpate the aorta in this patient?
Sorry, sir.
Did you palpate the aorta?
Yes, sir. I palpated the aorta.
Where did you palpate it?
So aorta was palpated midway between the Xiphis sternum and umbilicus, just to the left of the midline.
And you were able to palpate that in this patient?
Yes, sir.
And there was no thrill there?
No thrill, sir. I couldn't appreciate a thrill, could appreciate pulsation.
Okay.
You said a bruit.
Yes, sir.
No, pulsation is different from bruit. What you actually whether you had, but it is very unfortunate and difficult to palpate your aorta at that point, and also feel a pulse to get a bruit also.
In fact, Swapnil, if you can palpate the aorta in such a patient, you'll think of an aortic aneurysm.
Okay, sir.
Right?
Mm-hmm.
Okay. Can you show us the photograph of the affected foot?
Yes, sir.
Okay. So just by looking at the foot, which vessels do you think are involved? Which artery vessels are involved?
So more likely involvement of the posterior tibial. Sir.
Okay, posterior tibial supplies which angiosomes?
Posterior tibial, sir, mostly supplies the great toe and the medial great toe, second toe, and the medial half of the third toe. Sir.
Look, the great toe has got both anterior tibial and posterior tibial supply, right?
Yes, sir.
And the other toes have got from the posterior tibial.
Posterior tibial.
So the posterior tibial has the lateral plantar and the medial plantar and the lateral calcaneal. These are the three angiosomes. While the great toe has anterior tibial and posterior tibial. So probably it's the posterior tibial, and maybe because the great toe seems. Have you got the photograph of his sole?
Sole, I don't have a photograph, sir.
Was it involved anywhere? Must have been.
Yes, sir. The plantar surface of the toes is involved.
So it's important to give us a photograph of the plantar surface also.
Yes.
Right. Because it's very important, not just to so that we know the extent of the gangrene.
Yes.
Is the patient is having local edema?
Yes, sir. There is local edema present.
But you said it is a dry gangrene, no?
Yes, sir. There are.
Why the dry gangrene produce an edema?
So there is a secondary infection setting in the dorsum of the foot, sir. There's some component of cellulitis also present.
So mixture of all. But what any signs of ischemia is seen on the foot? Any trophic changes?
Yes, sir. There is loss of hair seen. And
no, do you know before examination? Are you sure there were hair?
Yes, sir.
How do you know?
Sir, on the contralateral limb, the right leg, hair are seen right up to the.
So why there is a hair loss? Why do you have the hair loss in ischemia?
So the hair loss is due to autonomic dysfunction, sir.
No, nothing to do with autonomic in the hair loss. You get a sweating can happen in the autonomic.
Yes, sir.
So all that is called as a trophism or a trophic change. It's the nutritional. The cutaneous blood supply will be lost. That is why you are having a loss of fat. You are going to get the skin appendages will go for a less death. So all these are nutritional changes because of lack of blood supply to like the carotid steal syndrome. Here the stealing blood will not come to the cutaneous. It will go there. But on looking at your leg, you are not able to see any trophic changes. Especially Sennheiser is very particular to say the hollow, that in between the toes you get a halo in the case of ischemic limb. So that is not also obviously seen there.
Yes, sir.
You must mention about the web space involvement.
Yes.
Web space involvement.
So please.
So you are able to say line of demarcation is there?
On the second toe, line of demarcation is seen, sir. But
what do you mean by line of demarcation?
So line of demarcation.
What do you mean by that line of demarcation?
So it is the separating zone between the well-perfused tissue and.
We are not asking line of we are not asking line of separation. Line of separation is different. Line of demarcation is different. So what you will get in the demarcation site?
So there will be a hyperemic line.
Hyperemia will be there. Hyperesthesia will be there. So all that you were able to note that.
Yes, sir.
In an associated cellulitis surrounding area, I think it is very difficult to note all those points. But if you have already noted, it is fine. Okay. But you have not mentioned about that, the trophic changes, the nail changes, all that should be, when you are examining the leg, you should put all the features what you are looking into that.
Yes, sir.
Swapnil, again, coming back to the temperature of the limb, you said
Yes, sir.
you palpated from the distal to the proximal or proximal to the distal?
Sir, I said distal to proximal.
But it should be proximal to distal.
Proximal to distal.
Right. So because it is better appreciated after you have felt the hot and then the cold, rather from the cold to the hot. You know? So you want to see that where is the change in the temperature is there. So you start from the thigh and go to the foot, rather than from the foot to the thigh.
Okay, sir.
Okay. Yeah. You can go to your diagnosis now again.
Yes, sir.
Yeah. So you are keeping a possibility of Berger's here, but we are keeping the possibility of the atherosclerosis. Okay.
Yes.
Based on that, you investigate this patient.
Why do you call this a critical limb ischemia?
So there is features of critical limb ischemia such as rest pain, tissue loss, gangrene.
Where was the rest pain?
Sir?
Where the patient experienced the rest pain?
Sir, that is because of the cry of the dying nerve, sir.
No, I'm not asking that. Where exactly the pain was there for the patient?
So, right, patient has pain in the foot, the entire foot and the distal 1/3 of the leg.
No, if the patient has the pain at the calf, that is a claudication pain normally you get. So you don't get the rest pain at the calf.
Yes.
Why do you get the rest pain at the foot only? Commonly?
So the foot.
If there is any logic, the nerve which is farthest from the heart will be affected most. What is the nerve in the foot which is involved?
So the peroneal.
Peroneal. What is the nerve in the foot supplying the muscles?
So tibial and peroneal.
Tibial is a nerve, it comes the leg, that is divides. Okay. Medial plantar, lateral plantar. So the farthest nerve will be there, that will be producing the rest pain. So this patient has a rest pain and gangrene.
Yes.
So what you graded, the Fontaine classification or the Stanford? You are not done. Okay, go ahead.
Sure,
Fine.
Yes.
No. Again, one more question, because you have said aorta is involved. Then why do you want to put as a femoral papillary segment? Why not it is aorta iliac segment?
Yes.
According to your finding, there is a bruise there in the abdominal aorta.
Yes, sir.
And so it must be. Are you sure you want to put it as a femoral popliteal or as aorta iliac?
So the patient does not give any history of gluteal claudication or thigh pain. So I was more in favor of.
Surgery is like a mathematics only. We can't change things here and there. But once you say that is according to you, aorta is involved. Whether it is right or wrong, that we have not seen that. But once you put aorta is involved, and then making it as a femoral property means there is a proximal to that is always normal. So be careful on that. Okay, go ahead.
Mhm. Should I proceed, sir?
Yes, please.
Yes. So this patient came to our OPD with Doppler reports. Sir. In the left lower limb, a long segment occlusion of the left external iliac and common femoral artery was noted, and there was no flow demonstrated distal to the common femoral arteries. And in the right lower limb, they have not mentioned any finding as such on the Doppler. We worked up the patient further, sir. A few blood investigations were also done for the patient, such as the complete blood counts, the renal function tests, fasting lipid profile was done for this patient, and the sugar profile was also done. And the patient then underwent a CT aortogram with peripheral angiogram, which
So
showed
in this, according to your Doppler, there is no flow in the femoral. Then how did you got a bruit there? Clinically, you said there is a bruit.
So distal to the common femoral, I got a feeble left femoral. Sir. Bruit was
External iliac itself is not functioning, no? And how can you get a flow coming into the common femoral if there is no flow in the external iliac?
I think bruit in the right side, sir. Right lower limb.
Bruit is on the right side, sir.
Right side. Bruit.
Okay. Go ahead.
Yes, sir. A CT aortogram showed a calcific plaques in the right and left common iliac arteries both, and luminal narrowing.
Swapnil, one second.
Yes, sir.
We don't want what the patient had already done, what investigation patient already have. What we want you to tell is what are the investigations you are going to do. That is a part of management, no? We want your management, not the somebody else's management. This is somebody else's management, no?
Yes, sir.
Already they have done it. Okay, we'll discuss that later. But now you have to tell what are the different things you would like to go ahead and do, and what are the different things you would like to see. Suppose color Doppler. What are the different things you would like to see in color Doppler?
Yes, sir. First, I'd like to see using the handheld Doppler also, sir. Bedside.
What are the different things you would like to do in handheld Doppler?
Yes, sir.
No, you are having a handheld Doppler with that, and what you can find already your limb is an ischemic limb. What do you look in for that?
So the I can check for the ABPI using a handheld Doppler.
Okay. Which artery you will feel for angle pressure?
Sir, we take the anterior tibial and the posterior tibial arteries.
No, you are taking both, and which one will be taken for consideration?
So we'll take the higher value of the two, sir.
In a brachial?
In the brachial also, sir, the higher value of we check pressure in both the arms, and the higher one is taken.
So what else you will do within your Doppler, handheld Doppler?
What is the normal ABPI?
So normal is considered 0.91 to 1.3, sir.
1.3.
1.3, sir.
Okay. If it is above 1.3, what does that mean?
Above 1.3 indicates a severely calcific, non-compressible vessel, sir. Severely calcific wall.
Okay. Now, if you find that you are not able to appreciate the pulsations by the Doppler also in the lower limb,
Yes, sir.
then what can you do to know whether the limb is ischemic or not?
Sir, we will go for a Duplay scan, sir, which involves the color and the velocity of flow.
Now, any pressure studies you can do?
Other than angle pressure, any other pressure you can measure?
Toe pressure can be measured, sir.
How much is the normal toe pressure?
Normal toe pressure is more than 30 millimeters of mercury, sir. Normal range is considered to be 50 to 70 millimeters of mercury, sir. Less than 30 is. Yes,
in
sir.
which conditions would ABPI not be valid? In diabetics, because there's thickening of the artery.
Yes, sir.
And in elderly, when there's calcification.
Yes, sir.
So in these two conditions, ABPI would not be valid.
Yes.
Even in CKD patient, they can go for the calciphylaxis. In the chronic CKD, there will be the vessels will be good. Then why do you spare? Then why if there is ABP is due to calcification, why do you want to measure on the toe? What is the principle of that?
So B mode ultrasound gives the direction of flow also, sir.
No. What is B mode? What the B stands for? What do you mean by B mode? B stands for brightness mode. It is not saying the direction. No, it is only the brightness. You have a great B mode. So when you are using the term, you must know what is the A mode, the B mode, TM, and M mode. So the principle is when the digital vessels are normally will not go for a calcification. So all the other arteries will go for a calcification because you have either dorsalis pedis or tibialis arteries can get calcified, but not the digital vessels going into that. That is why we will be going for a digital pressure measurement, toe pressure.
Yes.
Any transcutaneous oximetry you can do?
Yes, sir. Transcutaneous partial oxygen pressure can be, partial oxygen gradient can be seen, sir.
So what do you want to do for this patient?
Sir, I would like to further evaluate this patient if any vascular intervention is possible.
What is the difference between a Doppler and the duplex?
So Doppler is only the sound that we get from it's basically the reflected sound from a moving column of blood. And Duplay also gives us the color patterns, whether the flow is antegrade, retrograde, and also the velocity.
So what is the ultrasound? What is Doppler and what is Duplay?
So ultrasound is sound waves being reflected from a object at rest, or stationary object.
So what does it give? Broadly, what information does it give? The ultrasound.
Ultrasound information is visual image, sir. Image produced by the reflected sound, which is
not the reflected sound there. It gives you the anatomy. Okay. While the Doppler will give you the physiology. It will tell you about the flow of the blood which is there. And Duplay is a combination of that. That when you want to see the anatomy, you want to see the, like there is extrailiac arteries there, the femoral arteries there, you want to see that, or is there any thrombus which is there inside that or not. So that will be given by the ultrasound. You want to see the flow of that, how much the flow is there. What is the normal flow in the artery? What type of the flow it is?
So normal antegrade.
What type of the flow?
What phasic? How many? You get a Doppler, no? What is the normal you get in the Doppler? Is it monophasic, biphasic, triphasic?
Monophasic, 3 phases are monophasic, biphasic, and triphasic.
So which is normal?
What is
normal? Is triphasic flow, sir.
Yes, triphasic is normal. Then it becomes biphasic and then it becomes monophasic. Okay, so that is given by the Doppler. And when you want to see the both, it is a duplex. So
Yes.
what the report you are showing, it is not the Doppler, it is the duplex scan which is there.
Yes, sir.
What is meant by monophasic flow? Which flow is preserved till the last?
I couldn't hear you, sir.
Which phase of the flow will be preserved till the last moment in a ischemic limb?
So monophasic will be,
Monophasic, I agree, but which phase?
so that is the late systole phase, late diastole phase.
Yes, that will be usually preserved till the last moment.
Yes.
Yeah. Apart from that, what information would you like to get in a Doppler?
So Doppler will give.
I mean to say it's in a duplex.
Yes, sir. The information that can be obtained is first of all the kind of occlusion. If it is stenotic or if a thrombus can be picked up on a Doppler, intraarterial thrombus. The extent of the length of occlusion and the degree of occlusion is also seen on Doppler.
What is occlusion and what is stenosis?
So occlusion is intraluminal, such as thrombus or embolus or atherosclerosis. Stenosis is narrowing of the arteries. It can be due to an external compression.
Yes. Yes.
Swapnil, you have valid two investigations, right?
One second, sir. 1 second. My
Yes,
question.
yes, sir. Yes, sir.
Yeah. Any other additional information would you like to get? The length of the occlusion you said, the site of occlusion you said. Any other information? What is meant by distal runoff?
Yes, sir. There is. We can get information about the collateral circulation also, sir. If there is distal perfusion detected distal to the site of block, then we can say that there is collateral circulation.
So what is meant by distal runoff? Exactly.
Not sure, sir.
So an artery will be occluded for a length of the let us say 10 centimeter length, and the flow will be reappearing after that.
Yes, sir.
Because of collateral supply.
Yes, sir.
So that we call it distal runoff.
Yes, sir.
Okay. So a part about 10 to 15 centimeters of the artery will be occluded. Distal to that, it reappears. That is called distal runoff. This
Yes,
is
sir.
usually by collaterals. It is
Yes,
not the presence of collateral which is called distal runoff. It is the distal artery patency. Why
Yes,
it is important?
So that will we can plan for a bypass procedure if the distal.
Only when there is a distal runoff, we will be able to plan for a bypass.
Yes.
Isn't it? Yes. Okay. Go ahead.
Yes.
Swapnil, we had two investigations at your hand, no? You said I want to do further investigation. I think there is no need. With this, how will you proceed? And if you want to do arteriogram, is there any indication of arteriogram in this patient?
So they in a Doppler.
When you do arteriogram, in case of peripheral vascular disease. So when you want to intervene at the same sitting,
Yes.
like endoluminal surgeries, right?
Yes.
Stent placing, balloon dilatation,
Yes.
thrombectomy, thrombolysis, etc. You can do arteriogram. How will you proceed this patient? What is the treatment? Surgical or medical treatment of choice? Is there any role of surgery in this patient? Is it single segment lesion or multi-segmental lesion?
Multiple segments are also.
Including the small vessels also.
Small
Okay.
vessels.
So, is there any role of surgery in this patient?
Currently, no role of surgery, sir.
Yes. That should be the answer. There's no role for surgery. Okay.
Yes.
So, how will you manage this patient?
So we can attempt intravascular procedures, like stenting.
Yeah, that's what I told, there's no
Yeah. Yes.
role of any intravascular or endovascular procedures or surgical procedures. Okay. There is a single segment occlusion, we can do interventions, endarterectomy, etc., thrombolytic, thrombectomy, etc. Here, medical management, you said, what type of medical management will you, what will do for the gangrenous limb? Is it a gangrene limb? Is it a critical limb ischemia, right? Left right limb. For that, you have to do something.
Yes.
What will you do?
So
the general message, what will you do? Before that, you arrive at diagnosis, whether it's due to atherosclerosis or Buerger's. Still, you want to stick out to Buerger's or atherosclerosis?
So more likely atherosclerosis.
Yes. Okay. So medical management to be taken care of for atherosclerosis generalized, and to that left lower limb, you have to do some interventions, surgical interventions. What will you do?
So
not as a therapeutic measure, not a therapeutic. You cannot restore the blood supply. Okay.
Yes.
You will take care of the limb to prevent further sepsis and all that.
Yes.
Yeah. What will you do?
So we have to observe for any changes of.
Yeah, you have to first debride the limb,
Yes.
Yes, some edema is there, some gangrenous stones are there,
yes.
Skin gangrene is there, fasciotomy is needed or not, edema, limb is there.
Yes.
Then you have to further evaluate, wait for some time, whether gangrene proceed or not, then go for amputations.
Yes.
Either guillotine or planned amputations, below knee, etc. Okay. Yes.
Yes.
Suppose if you don't operate on this patient, what happens to his toes?
Faculty, any other question?
Sir? Hello?
Hello, sir.
Yeah. Continue. Suppose if you don't operate on this patient.
Dr. Swapnil, do you have any doubts to be clarified?
No, sir.
Dr. Swapnil?
No, sir.
No doubts. Srinivas sir, Saravanan sir, do you have any comments or can we call this a close, sir?
Yeah. I just asked one question, sir. So
Yes, sir.
what happens if he doesn't do any surgery for this patient? That's what I asked.
So generally, if the dry gangrene progresses, it can get auto-amputated, sir, because.
Yes, it will be auto-amputated. So where does it auto-amputate?
Sir, at the line of demarcation.
The line of demarcation. So what do you find at the line of demarcation pathologically?
Pathologically, sir, there will be a hyperemic
areas with granulation.
Yes.
So it heals better with those granulations.
Yes.
So don't be in a hurry to amputate the limb. Try to restore the rest of the blood supply.
Yes.
Yeah. That is the final comment. I won't like.
Can you just show the angiography film here? What
yes,
is the picture of the angiography? Yeah.
I'll show you the image, sir. This is the aortogram, sir.
Yes. So,
bilateral common iliacs are blocked in this, sir.
So why you are saying that you will not offer the surgical treatment to this patient?
So there are
very short. It's a very short segment only is blocked.
And probably the distal runoff is good here. No?
Yes, sir.
So this is, I think, a very good case for either the endovascular treatment or the open surgical treatment.
Okay, sir.
Yes.
Here, if there is just a block at the external iliacs are there, and then you can do a aortofemoral bypass here. Bilateral aortofemoral bypass can be done. Or even on the left side, if you see there is a long segment of the femoral is also involved, then you can take a long segment and you can go below that, above the popliteal.
Yes.
So I think this is a good candidate for the surgical intervention. Yeah.
That's what we were discussing while discussing about the duplex scan, the distal runoff. Here, the distal runoff is clearly good. So that is definitely he's a candidate for bypass.
Okay, sir.
Okay. Right. Thank you.
Okay.
Shall we go for the next case, sir? Kanagwal,
Yes,
sir.
sir.
Okay.
Thank you, Dr. Swapnil.
Yes. Thank you, sir. Thank you for the
Thank
opportunity,
you
sir.
for joining us this evening. I thank your department chief, Dr. Dinesh, and your head of the department also. Friends, now we move on to the next case. Dr. Shubham Gupta, kindly contributed by Professor Kanna, sir, and Seema Kanna, ma'am. Dr. Shubham, can you try sharing your PowerPoint? Swapnil, you can stay with us.
Yes, sir.
Dr. Shubham.
Hello, am I audible, sir?
Shubham, you have to switch on your video, Shubham.
Yes, sir. Am I audible, sir?
Yeah, you are
Yes.
perfectly audible. Yes, now you are okay. We are unable to see your PowerPoint, Dr. Shubham.
Now, sir?
Yes, perfect. Make it full screen, Kana.
Is it okay, sir?
Sujata ma'am, are you with us? Okay, let Dr. Sujata ma'am join, but you please go ahead, Dr. Shubham. Faculty, kindly take over.
Good evening, respected teachers. Today, I, Dr. Shubham Kumar Gupta, second year junior resident from Institute of Medical.
Dr. Shubham, I
Yes,
think
sir?
you are sharing your screen. We are unable to see you. Please unshare this. Okay. You please share only the PPT. Don't share the screen. If you are doing that, then we are unable to see you. You are unable to do that.
Yes, sir. I'm able to do that. Sir, I've shared the PPT.
Go to share screen.
Yes, sir, share.
Don't share the screen. Share only the PPT. Okay, you do whatever way you know, but we are unable to see you when your PowerPoint is coming. But then if you are not able to do it, please go ahead. Let us not take time on doing it.
Good evening, respected teachers. Today, I, Dr.
I'm unable to see your slides, Kana.
Now, sir?
Not it.
So can you see it?
Open the PowerPoint now.
So, good evening, respected teachers. Today, I, Dr.
Yes.
Shubham Kumar Gupta, second year junior resident from Institute of Medical Sciences, IMSBHU, is going to present a case. Professor Ike Khanna sir will be moderating the session. And my head of the department is Professor Seema Khanna. My guide is Professor Sanjeev Kumar. So,
Shubham, you need to come closer to your mic, ma.
A 69 years
remove
old.
the headset if you are using the cable. Your voice is very low.
A 69 years old male
Yes.
presented a male resident of Bhadohi, Uttar Pradesh, Hindu by religion, farmer by occupation, presented to surgery OPD of Sir Sundarlal Hospital with chief complaints of growth over penis for last 6 months, inability to retract foreskin for 4 months, and swelling over both the groins for 1 month. Patient was apparently well 6 months back when he noticed painless growth over penis, which was insidious in onset, rapidly progressive over following months, and associated with foul smelling puerine discharge, which was scanty in amount and occasionally blood stained. He complains of inability to retract foreskin beyond the glands for last 4 months, something that he could do earlier without any difficulty. There is associated history of whitish discoloration of foreskin, which he has for past 6 years. As it did not bother him, so he never took consultation for the same. He also complains of painless swelling over both the groins for 1 month, which he noticed on right side first, followed by left. These swellings have gradually increased in size since first he noticed it. It is not associated with any ulceration or discharge. There is no history of difficulty in passing urine or any urinary complaint, no history of loss of weight or appetite, no history of fever, no history of penile trauma, no history of jaundice, chest pain, hemoptysis, or breathing difficulty. On inquiring about the past history, he had no comorbidities associated. There was no surgical intervention in past. He consumes mixed diet and has been smoking BDs for last 25 years, 3 to 5 BDs per day. There is a history of poor genital hygiene. He is married with 2 children. No history of any sexual exposure to multiple partners or commercial sex workers. Bladder and bowel habits are normal, and appetite and sleep cycles are regular. The family history is not contributory. He presented to Sir Sundarlal Hospital surgery OPD for the first time and had underwent no workup before that. So summarizing my history, a 69 years old male smoker presented with growth over penis for last 6 months, associated occasionally with foul smelling, scanty purulent discharge, inability to retract foreskin since last 4 months, which was associated with whitish discoloration of foreskin for 6 years. History of painless swelling over both the groins noticed 1 month back. There are no associated urinary complaints.
Shubham, can I ask a question?
Yes, sir.
Hello.
Yes, sir.
Audible, am I? Yes, yes. You said some whitish appearance in the foreskin, 6 years for the past 6 years, followed by swelling over the
Yes, sir.
penile.
Yes, sir.
Okay. What is any significance of this whitish lesion?
Sir, actually, I tried to elicit whether there was any
Okay, leave alone. Leave alone. There is a history of whitish appearance on the foreskin.
So it is for past.
Significant?
Yes, sir. Actually, it contributes to possibility of lichen sclerosis, sir.
Yes. That is very important.
Yes, sir. Which predisposes to secondary phimosis, sir. Which in turn leads to, might lead to CA penis.
Yeah, BXO is usually neglected.
Yes, sir.
It's a predisposing factor for CA penis. Okay.
Yes, sir. Yes, sir.
Also, you are not mentioned about streaming of urine, whether he passes normal.
Sir, actually, I mentioned that he has no urinary complaints.
That you have to specifically say he is passing urine normally, or there is any change of the stream of the urine like that.
Yes.
You have to be specific on this occasion, okay?
Yes.
Pertaining to this patient.
Yes, sir.
Also, you are told swelling. There is no discharge from the swelling or
sir,
ulceration.
I have told there is a scanty foul smelling discharge, sir.
No. Groin swelling. When
mentioning
about groin swelling.
Yes, sir. Yes, sir. Yes, sir. It is not associated with ulceration, discharge, or anything.
Yeah. Swelling will not have discharge usually. You won't say. Usually ulcer, you have to say discharge. Okay.
Yes, sir.
Yes, you can proceed. Yes.
Yeah, 1 second. You go back to chief complaints.
Chief complaints. Yes, sir.
Growth over the penis. I don't know whether the senior faculty will agree with that or not. So, are you going to describe the rest of the thing as an ulcer or a swelling?
So, on examination, sir, actually the patient said about the growth because, sir, it was not like fungating or coming out or very evident, sir. If you permit, sir, may I show the clinical photographs first, sir?
Yeah, sure.
So this is the clinical photographs. So as we can see, here is the swelling, sir. And on retraction of the prepuce, sir, which is partially retractable, sir, we can appreciate, sir, this is the normal gland, sir. This is the meatal opening. This is the meatal opening, sir. This is the normal gland. And this is the growth, sir, circumferential growth, sir, with ulcerative proliferative lesion, which I will describe later, sir. And this is the hypopigmented lesions.
You try to call this as a lichen sclerosis. There is a whitish area.
Yes, sir.
We're not leukoplakia.
Sir, actually, leukoplakia is diagnosis of exclusion, sir, and sir, it involves the mucosa, sir. While sir, BXO is associated, involves both skin as well as mucosa, sir. And sir, leukoplakia more often is described for oral cavity, sir. Actually, I discussed the same with the derma faculty of our.
Okay. But the circumferential total involvement, the lichen sclerosis, and you say that is predisposing to the development of the malignancy. How long this is there? 6 years. Shubham?
I think he has some challenge.
Yes, sir. A small suggestion, sir. Kanagavel, sir. Sir, are you able to hear me, sir? Hello?
Dr.
Yes, sir.
Shubham, are you with us?
Are you able to hear me, sir? Kanagavel, sir. Hello? Hello? Hello?
Sorry, sir. I could not. Lost connection. Yes, sir. Sir, I've rejoined, sir. Sorry, sir.
Okay. Sir, he is rejoining, sir.
Sorry, sir. I lost connection, sir.
No problem. Please proceed.
Yes, sir. Should I proceed with the examination, sir?
Sharunan sir and Srinivas sir, can you start from there?
Yeah. Yes, sir.
Please go ahead.
Okay. We are not able to see his presentation screen. Presentation screen is not seen, sir.
Yes, sir. PPT is not on the screen, sir.
Shubham, you have to reshare the PPT.
Okay, sir. Sorry for the internet. Yes, sir. Is it okay, sir? No?
Yes. Good luck. Switch on your video also.
Sir,
Please carry on.
sir, should I continue with the examination?
Yes.
Yeah.
So patient was examined in well-lit room with informed consent, and patient was cooperative, well-oriented with time, place, and person. At the time of examination, he was afebrile, pulse rate of 88 beats per minute, regular normovolumic, blood pressure of 114/76 millimeter of mercury, respiratory rate was 16 cycles per minute, thoraco-abdominal. His ECOG score was 1, Pallor was present. There was no icterus, clubbing, cyanosis, pedal edema, or any generalized lymphadenopathy. So this was the clinical photograph. So on inspection, penis is approximately 10 centimeter in size, in length, with swelling of distal half of the penis, a circumferential ulcerato-proliferative lesion present at distal end of the penis, surrounding the glans with ill-defined margins, everted edges, slough present at the floor of the ulcer, with minimal seropurulent discharge. A circumferential hypopigmented lesion is noted over the margin of the prepuce and its inner aspect, while the outer surface of the prepuce appears normal in color. A small part of the glans, along with the external urethral meatus, is visible. Bilateral testis, scrotum, and perineum appears normal. On palpation, there was no local rise of temperature, no tenderness palpable. A non-tender hard circumferential ulcerato-proliferative lesion of 7 centimeter circumference is present at the distal part of the penis, with induration extending into the distal half of the shaft of the penis. Scanty seropurulent discharge present. Proximal extent of the induration lies 5 centimeter from the root of the penis and 5 centimeter from the meatus, that is midway, both on the dorsal as well as the ventral surface of the penis. Overlying prepuce is thickened and induratory and cannot be retracted back beyond corona glandis. Proximal urethra is normal on palpation, but the distal urethra could not be palpated because of the induration. The scrotum, bilateral testis, and cord structures are normal. On lymph node regional lymph node examination, single right superficial inguinal node of size 2 by 3 centimeter, mobile, firm, non-tender, is palpable. On the left side, 2 superficial inguinal lymph nodes of size 1 by 1 centimeter and 2 by 2 centimeter, firm, mobile, non-tender, was palpable. Overlying skin was normal. There was no fixity to overlying skin or underlying tissue. The other lymph node, regional lymph nodes were not palpable. On per abdominal examination, abdomen was soft, non-tender, no lump, organomegaly palpable. Bowel sounds were audible. DRE was within normal limits. Systemic examination revealed no abnormality. Summarizing my case, a 69 years old Hindu male smoker presented with growth over penis for last 6 months, associated occasionally with foul, smelly, scanty purulent discharge, inability to retract foreskin since last 4 months, with associated history of whitish discoloration of foreskin for 6 years, history of painless swelling over both the groins noticed 1 month back. There was no urinary complaint. On examination, hard circumferential ulcerato-proliferative lesion of 7 centimeter present at the glans and distal part of the shaft of penis, which is fixed to skin and underlying structures. Proximal extent of the induration lies almost midway between the root of the penis and the external urethral meatus. There is circumferential hypopigmented lesion involving the prepuce associated with secondary fibrosis. Bilaterally enlarged, firm, mobile, superficial inguinal lymph nodes are palpable. So my provisional diagnosis is carcinoma of penis with bilateral inguinal lymphadenopathy, with lichen sclerosis with secondary phimosis. Jackson's staging is stage 3 and clinical stage is T2 or T3 lesion, N2, M0.
Shubham, can you focus the photographs?
Yes, sir.
See, on inspection, there is a phimosis, you know. Hello, Shubham?
Yes, sir. Actually, sir.
Phimosis, the glans is covered.
Yes,
then you have described the swelling, about the swelling over the glans penis, size, shape, and all that. And palpation only you can able to retract. That's also not possible in this patient. That you have to ascertain whether inspection there is a swelling over the glans region covered by peripheral skin. That's what how you have to explain about the swelling.
Yes, sir. Yes.
Okay.
Yes.
Then you said describe the swelling involving the glands as well as the shaft. You say there is any continuity of the swelling because you have said the skin is not able to retract it beyond the glans penis. Then how can you examine the
Sir, it is partially retractable, sir. As you can see in this picture, sir, it is partially retractable.
Yeah, shaft of the penis also, to some extent, you said the swelling encroaches. Okay. What I mean to say is, induration you have to mention. You have to mention like that, induration. You have to describe the swelling or the glans penis and how far the shaft is indurated or extended. You should not describe, I said, in toto.
Yes.
The swelling as well as induration of the, you should not combine the swelling as well as induration. Okay. You have to describe the swelling of the glans penis or the glans penis and how far the extent it is extended by palpatory method. Okay.
Yes. Yes, sir.
You said the induration. So the induration is extending about 5 centimeters into the glans. Sorry, into the
Shaft of the penis. Yes, sir. Distal part of the shaft.
So at the same time, you're also telling that the edges. You're describing something about the edges. Is it possible to see the edge in this case?
Sir, I have not described the edge, sir.
1 second, Subham. Why I am telling this is because most commonly, in case of carcinoma of the penis, two things you get confused. Most of the posterior. This is for the sake of posteriors. Whether to describe it as a swelling or an ulcer.
Yes, sir.
As you rightly pointed out, it is described as ulceroproliferative lesion. So that is a non-committal. So we have both the features of swelling as well as the ulcer. But you keep on telling the parts of the ulcer, like the margins, the edge of the ulcer, the floor of the ulcer, rest of the things you describe just like in case of an ulcer. Here, of course, the whole glans is swollen. I can understand that. You are not able to retract the prepuce. That's the reason why the margin is not able to see. Margins are not seen in this case.
Yes, sir.
But at the same time, you are telling what are the different points you describe about an edge of an ulcer?
So different points to describe regarding the ulcer, sir?
Yeah.
Sir, starting from the site, location, is number, site, then shape, sir, then the margin, the edge, the floor, and then on palpation, the base, if there is any discharge, sir, surrounding skin.
So regarding the edge, what are the different things you describe on palpation?
Regarding the edge, sir, sir, whether the edge is sir, sloping edge or it is everted, rolled out. These are the various
the type of the edges, as well as you have to tell the induration, how long how far the induration is there beyond the edge of the ulcer.
Yes. Yes.
So that gives you, suppose if the ulcer is present somewhere in the shaft of the penis, let us say.
Yes, sir.
So then you can say the extent of the induration you need to excise, isn't it? If at all.
Yes, sir. Yes, sir. Yes, sir.
Not in this case, in general. So in general,
yes, sir.
I am telling you. So at the same time, you have to tell on palpation, you have to tell the induration of the base of the ulcer. So that is for 3-dimensional excision. So in case of an ulcer, we excise both the breadth, width, as well as the depth of the ulcer.
Yes.
So this is to clear confusion. This is just to clear your confusion for all the postgraduates. Yeah. Okay. Then one thing is that you said about the lymph nodes.
Yes.
So what did you say about the lymph nodes?
Sir, I have mentioned about the site, number, and whether the consistency, whether there was tenderness or not. Sir, whether it was mobile or fixed.
Yes.
Overlying skin, its fixity to overlying skin, underlying tissue, and sir, associated with any other surrounding lymph nodes.
Yes. Okay. Go ahead. Yeah. Go ahead. How do you manage this case?
Sir, so I have to first, sir, confirm the principles of management include confirmation of the diagnosis, both for the primary lesion, sir, and then addressing the lymph nodes, sir. So for that, I have to go for certain investigations. So for primary, sir, as a extent of the clinical, as the extent of sir clinical examination, I would like to do, sir, ultrasound of the penis, sir, or better investigation would be MRI, sir, to delineate the depth of invasion, sir. And at this, along with that, I will go for a histological confirmation of my diagnosis, which will also help me to grade the disease, because grade of the disease, histological grade has very important aspect in the line of management. If it is grade 1 and grade 2, it falls in 1A, and if it is grade 3 or 4, it is high risk, that is falls in 1B. Sir, the histological type that is from a...
Shubham, will you like to keep any differential diagnosis in this patient?
Sir, differential diagnosis in this patient, sir, a growth like this, sir, sir, there can be other lesions, sir, which can be there, but so
what are the various ulcers of the penis?
Sir, the genital ulcer or the penile ulcer, sir, can be of infective origin, which is more common than non-infective origin, sir. Among the infective origin, it can be painful or painless. Among the painful, sir, it can be herpetic ulcer, or sir, it can be it can be because of, sir, soft chancre, sir, chancroid. Among, sir, a painless ulcer, it can be because of syphilis, sir, or it can be because of lymphogranuloma venereum, or, sir, among the non-infective, sir, it can be because of Beckett's disease, or, sir, it can be because of, sir, psoriasis, or, sir, because of, sir, trauma.
Can it be tuberculosis, sir?
Sir, yes, sir, tubercular ulcer can be there, sir.
So what is the characteristic of a tubercular ulcer? What is the characteristic of a tubercular ulcer?
Sir, tubercular ulcer will be, sir, hard in duration will be there, sir, like this ulcer, sir, and sir, there will be matted lymph nodes, sir, enlarged matted lymph nodes associated.
Ulcer. First, tell about the ulcer.
Sir, it will be nodular in characteristic rather than proliferative. It will be associated with induration. Sir, there will not be fixity to overlying skin or underlying structure, sir.
Whenever you're talking of any ulcer, the most important thing is the edge of the ulcer.
Sir, rolled out edges will be there, sir.
In tuberculosis?
Tuberculosis.
Sir,
in tuberculosis, you get a rolled out edge.
Sorry, sir, everted edges, sir.
Everted edge.
Not even everted. Okay, what are the various types of edges of the ulcer? Tell that.
Sir, it can be, sir, sloping edge, sir.
Sloping edge is a feature of
tuberculosis.
Sloping edge is a feature of healing ulcer, no?
Yes.
Okay, so healing ulcer is there. There is a sloping edge there.
Then there can be, sir,
punched out ulcer.
Punched out ulcer, sir, which can be because of trophic ulcers. Sir.
Trophic and any
sir,
other?
Sir, vascular origin, sir, like arterial or vasculitis ulcer, sir. Then there can be, sir, rolled out ulcer.
What happens in the syphilitic ulcer?
Sir, which ulcer?
Punched out ulcer is typically defined in the Syphilitic ulcers.
Yes, sir. Syphilitic ulcer, yes, sir.
Then
Sir,
you
there
have
can be
undermined edges.
undermining, sir, which can be seen in tuberculosis, sir. There can be, sir, rolled out ulcer, which is characteristic of, sir, basal cell carcinoma, sir.
And squamous cell carcinoma?
Sir,
What type?
in
What are the
malignant
differences?
ulcers, in malignant ulcers, sir, where there is everted edges, sir, it is more likely squamous cell carcinoma, sir.
What is the
Like
difference between the edge of a basal cell carcinoma and a squamous cell carcinoma?
Sir, squamous cell carcinoma, the edges are, sir, everted, but sir, in basal cell carcinoma, it is, sir, rolled out.
So
They're beaded. Okay, in basal cell carcinoma, they're beaded.
Yes, sir.
While in case of the squamous cell carcinoma, they are everted.
Yes, sir.
In the case of tuberculosis, you will get an undermined edges.
Undermined edges.
Right.
Yes, sir. Sorry, sir.
Tell what are the various pre-malignant conditions?
Sir, pre-malignant conditions can be, sir, HPV related, sir, or non-HPV related, sir. Among the HPV related, sir, erythroplasia of Curette, Bowen's disease, and, sir, bovinoid papulosis is the, these are the conditions, sir. And a giant condyloma acuminata, sir, that is Bushkin-Lowenstein tumor, sir. And non-HPV related, sir, lichen sclerosis, sir, cutaneous penile horn, and one more, sir, pseudo epitheliomatous mycaceous balanitis. These are the non-HPV related, sir.
where do you get erythroplasia of the Curette? Where do you get Bowen's disease?
Sir, the location of sir?
Are they pre-malignant or are they carcinoma in situ?
Sir, they are carcinoma in situ, sir. Penile intraepithelial neoplasia, sir. PEIN. Sir, the location wise, sir, erythroplasia of Curette is located on the glans penis, sir, and prepuce. And, sir, Bowen's disease is found on the shaft of the penis.
So on the skin surface, you'll get Bowen's. On the mucosal surface, you'll get erythroplasia.
Erythroplasia of Curette, yes, sir.
Now, what type of the malignancy develops over a leukoplakia in penis? What will be the characteristic feature of that if it is developing over leukoplakia? Like if it is developing over some polyps or some.
Sir, if it is developing over some polyps, sir, then it will be, sir, the proliferative, it will be a proliferative lesion, sir, cauliflower-like or
and in
cauliflower-like, sir.
Sir,
the ulcerative component will be more as compared to the proliferative component, sir.
It's more of indurated variety.
Yes, sir. And more indurated.
More of indurated variety.
Yes.
Right. So in this patient, what will be your first investigation? What you will do?
So the first investigation, I will go for, as an extension of clinical examination, I will go for ultrasound of the penis, sir. And for
why you want to do ultrasound? What information you are going to get by ultrasound?
Sir, the depth of invasion can be appreciated, sir, whether it is involving the corpus cavernosa and corpus corpora spongiosum, sir, that can be, so T2, T3 differentiation can be done on that, sir, clinically. And sir, urethra involved or not, sir, that information, though it is very in a very advanced disease, but that can also be delineated with a high resolution, good quality ultrasound.
So will that make a diagnosis?
No, sir. For confirmation of the diagnosis, sir, histopathological.
But you said that.
Yes, sir. Sir.
But you said that the induration is 5 centimeters proximal to the glans.
Yes, sir.
Hello.
Yes, sir. Yes, sir.
Hello.
Yes, sir. Yes, sir. I said, sir, it is 5 centimeter proximal
So
to
do
the
you think
glands.
so at that point, do you think the infiltration, the glands and corpus spongiosum and corpora cavernosa will be separate there?
Sir, it can be subepithelial variety, sir. Stage, sir, T1, sir. It can be because in duration, there can be, sir, underlying malignancy, which can be there, sir. Malignant cells can be there, but its involvement is whether restricted to the subepithelial layer or it is involving the corpora cavernosa, sir. So that, but sir, for confirmation of the diagnosis, I will definitely go for a wedge biopsy, sir.
So I think that should be a first investigation in this patient. Okay.
Yes, sir. Yes,
Because that is going to give you the diagnosis and
further
you
line.
can further. Yeah. So you should go. So how will you do a biopsy in this patient?
Sir, I will. So taking the the proliferative lesion, sir, as a broader, sir, the wedge of the margin from the margin as well as the normal skin, sir. I will take the wedge biopsy and will send it for HPE, sir. Preferably not using the local anesthesia, sir.
And
No,
what the
no,
pathologist
here you are
will
not able to see the edge, no?
Yes.
1 second. Here you are not able to see the edge, no?
Yes. So I will be sending
not able
biopsy from this area, sir. From the distal, sir, distal edge, sir.
this case.
Yes, sir.
So, Shubham, what type of the biopsy it will come out?
Sir, wedge biopsy, sir. Incisional biopsy, sir.
Yeah, you would do that. But what will be
Yes.
the biopsy report?
Sir, I'm anticipating that this will be a squamous cell carcinoma. Then I will be looking for the grade. Sir, grade of can be, sir, G1, G2, G3, G4, which is, sir, well differentiated, moderately differentiated, poorly differentiated, and undifferentiated. Then, sir, whether there is any vascular involvement or not, sir, invasion, that will be, sir, evident from the HPE, sir. These are the few things which I'm trying to.
How does the pathologist say it is a squamous cell carcinoma?
Sir, there can be, sir, if it is well differentiated, sir, then there can be, sir, keratin pearls can be there, sir. Bridges can be there, sir.
What other types of the carcinoma can come in that area?
Sir, if it is, sir, it can be, sir, arising from the glands of the glands, sir. So it can be adenocarcinoma or adenosquamous variety, sir. It can be basal cell carcinoma, sir. It can be malignant melanoma, sir. It can be Kaposi sarcoma, but not in this patient, sir. It is more common in HIV patients.
Any other variety? It is arising from the
vascular, sir.
Any other
sarcoma can be there, sir.
Suppose if it is arising from the epithelium of the external meatus.
Sir,
or urethra.
It can be, sir, of urothelioma.
Transitional cell variety.
Yes, sir, transitional cell variety.
So what is a varicose carcinoma?
Sir, varicose carcinoma or varicose carcinoma is, sir, well differentiated, slow growing, sir, YT type of lesion, which is locally invasive, sir, but not usually metastatic, sir. It falls under TA of the staging, sir.
Okay. Okay, go ahead with management.
So I will, sir, confirm the diagnosis from histological, sir. And sir, as bilateral inguinal lymph nodes are involved, sir, and the patient has foul sponge discharge, sir, I will start the patient straightforward on antibiotics, sir. Along with that, sir, I will not wait for the 6 weeks duration, sir. I will start the antibiotics and will continue the workup, sir. In which case, sir, I will go for, as bilateral inguinal lymph nodes are palpable, sir, I will go for FNAC from the lymph nodes, sir. And along with that, sir, another, sir, ultrasound of the inguinal region can be done to look for the nature of these lymph nodes, sir, whether they are reactive or they are metastatic. And sir, since if FNAC, sir, but in recent NCCN guideline, they recommend that if there is palpable bilateral lymph nodes, we should go for CT of the pelvis, sir. So I will go for CT of the pelvis, sir, CT of the pelvis to look for pelvic lymph nodes.
Well,
yes, sir.
To be practical, we have to start with, I will do, to take biopsy. You can do dorsal slit first. Okay.
Yes, sir. Yes, sir.
If you are planning
Yes,
immediate surgical treatment,
yes,
your
sir.
answer should be, I will do dorsal slit.
Yes, sir.
I will examine further the extent of the ulceroproliferative lesion and
Yes, sir.
take biopsy at the appropriate site. Okay.
Yes, sir. Yes, sir.
That should be your first line of management. Okay.
Yes, sir.
And
Yes, sir.
staging, TNM staging, usually it's after surgical specimen examination, so more of pathological staging. Okay.
Yes.
Also, in the examination abdomen, you are told no mass palpable. You should not say just like that, because inguinal nodes bilateral are palpable. When palpable, you have to specifically say whether extrailiac group of nodes are palpable or not. Okay.
Okay,
You have to specifically say nodes,
yes,
extrailiac group of nodes are palpable or not. That you have to be
yes,
specific. And when say
yes,
investigation, you are told MRI. MRI is
sir.
This locally advanced lesion, no? With it,
Sir, I said CT, sir, of pelvis.
yeah, you previously told MRI. You said MRI. Okay.
Yes. For penis.
Okay. Okay, that's all. We can proceed.
Yes. So, sir, if on
you have to carry out the Shubham MRI, what type of the MRI you will do?
sir, it will be contrast enhanced, sir, and at the same time, sir, it is known as pipe, sir, piperine injected, sir, penile erection.
So what is that called as?
Sir,
MRI
with sir artificial tumescence.
Yes, artificial tumescence or artificial erection should be there.
Yes, sir. Yes, sir.
Then only
Yes,
probably
sir.
you can exactly find out that what is the involvement there.
Yes.
Okay. Now, what about the lymph nodes here? How you are going to work up for the lymph nodes?
Sir, in my case, sir, bilateral inguinal lymph nodes are palpable, sir. I will go for FNAC, sir. Because bilateral lymph node palpable falls under, sir, palpable bulky inguinal group, and sir, then we have to go for FNAC, sir. If it turns out to be positive, then there are two lines of management. First, it should be associated with, sir, CCT of the pelvis, and if the pelvic lymph nodes are not palpable, sir, I will go for inguinal lymph node dissection along with the partial penectomy, sir, and will send the frozen section for the both the frozen sections for the histopathological examination. And if it turns out to be positive, then on the ipsilateral side, I will be clearing the pelvic group of lymph nodes. And if it doesn't comes, both the inguinal lymph node comes out to be negative, sir, on frozen section, then that will be enough for the surgical treatment, and then I will be followed the patient. If on FNAC it turns out to be positive, sir, then and the pelvic lymph nodes are present, then better option will be neoadjuvant therapy, neoadjuvant chemotherapy, sir, followed by definitive surgical management.
What are the various types of organ preservation surgery in cancer penis?
Sir, organ preservation surgery
Techniques,
is
yeah. Organ preservation techniques rather than surgery. Organ preservation techniques.
Sir, there can be, sir, surgeries can be, sir, Mohs surgery, Mohs micrographic surgery. Glanectomy can be done, sir. Laser therapy can be done. There can be wild local excision, sir. And sir, uh, glance resurfacing.
Yes.
So these are
Any other organ preservation technique?
Techniques, sir. Radiotherapy can be given, sir, and topical application of sir 5-fluorouracil or sir imiquinone can be.
Okay.
5-fluorouracil. For what do you give 5-fluorouracil?
Sir, it is usually given for TIS lesion, sir, or sir TA lesion.
Suppose the patient doesn't want any surgery.
Yes, sir.
Then what is the other option you can give to
If the patient doesn't want surgery, sir, then we are bound to offer him chemoradiotherapy, sir.
Yeah, in the form of?
In the form of, sir, TIP-based regimen, sir, which is, sir, paclitaxel, ifosfamide, and, sir, cisplatin, sir. And radiotherapy, sir, it will be external beam radiotherapy, sir.
What type of the radiotherapy you give in cancer penis for the preservation?
Sir, in preservation, sir, we can go for, sir, the external beam, sir, or sir, we can go for sir implants, sir, which we implant in the
Penile molds.
penile mold, sir, which is placed upon the surface of the penis, and then there is implant based, sir, which is interstitial radiotherapy.
Interstitial variety.
Yes, sir. The interstitial.
So where you use the brachytherapy and where you use the teletherapy?
Sir, brachytherapy is used, sir, when either the margin is positive and patient denies surgery, sir, or there is, sir, the high risk group, sir, where sir, lymph node size is more than 4 centimeters, sir. Positive lymph node size more than 4 centimeters, sir. There are extra nodal extension is there, sir. Or pelvic lymph nodes are positive, sir.
Brachytherapy is for the curative intent. Okay.
Yes.
While the teletherapy is for the palliative intent. Okay, if you have to cure, you have to preserve the organ, you will do the brachytherapy. But if it is such a advanced growth is there, advanced nodes are there, you are not able to do any surgical treatment, then it is the teletherapy.
Teletherapy, yes.
One is for the curative intent, another is for the palliative intent.
Palliative intent, yes.
Would you like to go for partial penectomy or total penectomy in this case?
Sir, in this case, sir, I will go for partial penectomy, sir, because the adequate margin is present to provide the person with a voiding function, sir.
So how do you measure the length of the penis? Before surgery, before anesthesia, or after anesthesia?
Sir, the flaccid penis penile length should be measured, sir. Flaccid penile length should be measured using the scale, and sir, the induration margin should be excluded from the measurement, sir, to calculate the stumps. And sir, negative margin should be ensured. The previous dictum of 2 centimeter tumor free margin is not followed now. Depends. It depends upon the grade of the tumor now. So, like in G1, we can go for 3 millimeter negative margin is acceptable. For G2, 5 millimeter, and for G3, sir, 8 millimeter margin is acceptable. So, it is the frozen section, and the negative margin is more important as compared to the fixed 2 centimeter margin which was previously followed.
Suppose you need to get extra length of the penis. How do you do that?
Sir, the oncological goal is the most important, sir. Oncological clearance is most important, sir. So as the then the cosmesis. So, sir, achieving a negative margin will be priority than to preserving as much as the penile length can be preserved, should be preserved. But, sir, negative margin is a priority. Achieving
what I'm asking is, are there any procedures to lengthen the penis? What is phallus lengthening? What is phalloplasty?
Sorry, sir. These are the these procedures I'm not aware of, sir. There are definitely, I've heard of these, sir, but I'm not certain of the details.
So in phallus lengthening, you will be dividing the suspensory ligament.
Yes.
So that you will get extra length of the shaft of the penis, if at all it is needed.
Yes.
In phalloplasty, you bring off surrounding tissues and reef off some part of the phallus from the where is the corpus cavernosa inserted?
So corpus cavernosa are inserted on the undersurface of the ischiopubic ramus.
Ischiopubic ramus. So we reef off about 1 to 1.5 centimeters from there, and we'll get an extra length of the corpora cavernosa.
Yes.
So that is again it's called phalloplasty.
Yes.
In addition to dividing the suspensory ligament. So these are the maneuvers to further get a length of extra length of the penis. Okay.
Yes.
Right. So what will you do for the lymph nodes?
Sir, I will go for superficial, inguinal, so not superficial. I will go for, sir, inguinal lymph node dissection, sir, and we'll send it for frozen section. If it comes to be negative, sir, then this defines the end of the surgery, sir, there. And if it comes to be positive, sir, on the side of the positive lymph node, I will go for pelvic lymph node dissection.
So what are the boundaries of inguinal dissection? What are the boundaries of ilioinguinal block?
Sir, what are the boundaries of?
Up to what extent you remove all the inguinal block dissection?
Sir, in inguinal block dissection, sir, we follow, sir.
And what are the boundaries of ilioinguinal block dissection?
Sir, your voice was missing, sir. What both of? Can you repeat the question, sir? Inguinal block dissection and?
Hello, can I ask
boundaries?
Sorry.
Sir, boundaries of, sir, the modified inguinal lymph node dissection, sir. It includes, sir, the femoral artery is the lateral most boundary, sir, and medial most is the adductor longus, sir. Inferior, accordingly, it is the fossa ovalis, and superiorly, it is the inguinal ligament, which defines the extent, sir. Saphenous vein is preserved, sir, and in this case, sir, transposition of sartorius muscle is not required, sir. So this is how modified inguinal lymph node dissection should be done. And it usually covers, sir, more medial superficial inguinal lymph node and central groups, along with the deep inguinal nodes.
Suppose you need to do pelvic lymph node dissection, then what are the boundaries?
Sir, in pelvic lymph node dissection, sir, the medial extent is the bladder, sir, and the lateral extent, sir, includes obturator nerve. Above it is up to the sir. Sir, above it is up to the common iliac, sir, and below it is, sorry, sir?
Up to the bifurcation.
Up to the bifurcation, sir, and below it is up to the genitofemoral.
Below up to the? So there is nothing like pure pelvic node dissection. It is included with the inguinal block dissection, isn't it?
Yes, sir.
So the lower extent of the inguinal block dissection will also come for the iliac node dissection.
Yes, sir.
Shubham, how do you take care of the urethral meatus?
In partial penectomy, sir, it is sir brought out through the same stump, center of the same stump, sir. And so using catgut, sir, or 30 Vicryl, sir, it is fixed to the. It is the end is spatulated, sir, and it is sutured with the stump, sir. And
So,
patient should be, yes, sir.
When you are making the flaps in the partial amputation, are they equal flaps or they are long and short flaps?
Sir, the above flap is, sir, kept shorter, sir, and below, I'm confused, sir. The one flap is smaller, sir, and other flap is longer, sir. And
Which
through
is
the longer flap, sir.
So superior is shorter, no?
Yes, sir. Superior is shorter, sir, and inferior.
And inferior is longer.
Yes, sir.
So that the suture line, it goes on the anterior side there.
Yes, sir. On the anterior side.
And you bring out the urethral meatus
To the center of the
to the inferior flap.
inferior flap. Yes, sir.
So the precautions which has to be taken is that there should be good vascularity of the, because if there is not a good vascularity,
yes, sir,
this is going to stenose.
Yes, sir.
And how do you take the sutures, and which sutures you usually take?
Sir, catgut is used, sir. The margins of the.
Nowadays, catgut is not used, no?
Or
Catgut
Vicryl
was there
is,
for a Vicryl is the
Vicryl 3040, yes.
Right. So they have to be the interrupted Vicryl sutures.
Yes, sir.
And some people, they split the urethra to make it slightly wider.
Yes.
Okay. Now, when you're doing the block dissection, how will you make the incision?
Sir, there are two ways to make the decision, sir. We can make a single incision for sir. One incision can be, sir, ileo. From the same incision, we will be accessing both, which will be extending, sir, above as well as below the inguinal ligaments. Sir, single incision approach. Or, sir, there can be, sir, two incisions, sir. One is made above the inguinal ligament, sir, or one below the inguinal ligament.
What are the various complications which can occur because of the block dissection?
Sir, there can be intraoperative complication like hemorrhage, sir, because of the adjacent vessels, sir, or because of, sir, the bleeding from corpora, sir.
No, inguinal block dissection.
Inguinal block dissection, sir. The
corpora is
complication
not there, no?
No, sir. Sir, for inguinal block dissection, sir, there can be bleeding from the vessel, sir, or there can be injury to the surrounding nerve. Sir, post-operatively, patient can have, sir, lymphedema, sir, lymphocele formation. There can be flap necrosis. There can be sir, DVT. There can be DVT.
What are the various ways to prevent the flap necrosis?
Sir, adequate thickness flap should be raised, sir. Preferably, sir, the flap is raised at the deep membranous layer, below the deep membranous layer, sir. That is Karpa's fascia.
So that is one. What are the other ways?
Sir, limited use of cautery.
Okay.
Third is, sir, securing the hemostasis. Fourth is, sir, ensure limiting the lateral extension, sir, because there is a number of perforators which are coming from there, sir.
Then there are others, like you can excise the central portion, you know, so that your flap is not very big, So you can make the elliptical type of the incisions, preserving the saphenous vein.
Yes,
And
sir,
then
preservation.
definitely you can go for the laparoscopic and the robotic surgery also.
Yes, sir.
You really want to prevent the flap necrosis, because that is the one of the most important thing.
Yes,
And
sir.
you have to also prevent the infection.
Yes, sir.
Okay. So these are the very important things to prevent the flap necrosis. Okay. Can you do any tumor marker for the cancer penis?
Sir, squamous cell antigen has been proposed in some literature, sir, but its utility is not well recognized in the NCCN guidelines. So there can be matrix metalloproteinase 9, sir, Ki67. Then there is one more, sir. Then there is tumor P53, sir. These are the things which these are the various markers, sir, which have been proposed, but they are not very useful, sir.
SCC antigen is the probably only one, but that is also in about 25% cases you can find the tumor, but otherwise there is no specific marker for that.
Yes, sir.
Now, what is the role of doing the orchidectomy if you are planning to do a total amputation?
So role of doing orchidectomy.
You know, when you are doing a total amputation from where the urethra comes out?
Sir, perineal urethrostomy is done, sir.
Okay,
So for which the urethra is mobilized to insert in the perineum.
So when you're doing the perineal urethrostomy, when the patient passes the urine, if there are big testicles are there, they
Yes,
may
sir.
be coming in the way.
Yes, sir.
Okay. So that is only to prevent the excoriation of the skin of that area.
Yes,
You may
very
go
good.
for the orchidectomy, but otherwise there is no role of carrying out orchidectomy in the patient with the cancer penis. Okay. Dr. Kanaval?
Yes, sir.
Can we stop here?
Yes, sir. I think we should allow the candidate if he has any doubt. Anyway, he's your student. But even then, Shubham, do you have any doubts or thing to clarify, Shubham?
No, sir.
Thank you very much, Kanna sir, for contributing your student. Thank you, Shubham. Faculty, any other questions or comments, sir? Saravanan sir,
Small point, sir. Small one point, sir, to conclude, sir.
Yes, sir. Please, sir.
I thank both presenters did well, sir. Practice only make perfect, so they have to improve little bit, sir. One more point regarding the addressing the inguinal nodes, sir. He said frozen section. He will do frozen section followed by ileal dissection. Yes, sir. Frozen section is not available commonly everywhere, sir. So, what the criteria to follow ilioinguinal block dissection is when the bulky nodes in the inguinal region, more than 4 centimeter like that, or extranodal spread, or multiple nodes, more than 3 or 4 nodes on bilaterally, can go for ilioinguinal. We can combine ilioinguinal block dissection, sir. That's all, sir. Thank you.
Thank you very much. Srinivas, sir.
Oh, what is the role of sentinel lymph node labs? Shubham, we didn't mention about that. Is there anything like that?
Shubham?
Yes, sir.
Sentinel lymph node biopsy.
Yes, sir. In case of non-palpable inguinal lymph node, sir, sentinel lymph node biopsy has a definite role, sir. Sir, in which, sir, the methylene blue dye is used, sir, and apart from it, sir, technetium labeled, sir, sulfur colloids is also used, sir, and handheld gamma camera is used, sir. So this gives idea about the sentinel lymph node, and that should be, sir, excised and sent for sir, biopsy, and and the reports according to that, sir, we can go for whether the pelvic lymph node dissection is required or not. We can plan accordingly, sir. Lymph node management.
What is Cabanas node?
Sir, it is It is the first, it is actually the sentinel lymph node or first lymph node to be draining.
Are told frozen section is not available everywhere. What we need to do is only bulky lymph nodes, multiple bulky lymph nodes, more than 4. We have to go for ileum block dissection.
Sir, we can. Yes, sir.
Robotics are the
Yes,
best
sir.
way to prevent flap necrosis.
Yes, sir. Robotics and
Because
brains.
laparoscopy or endoscopy, the ergonomics will not be good. Whereas in case of robotics, you can use your robotic arm because it's 360 degrees available. No, you can, I mean,
Yes.
make a curvilinear movements from
Yes.
below upwards. So that is the advantage with robotics. In particularly ileum block dissection. That's the best way to prevent flap necrosis.
Yes.
Okay. Minimal handling, preferably using hooks or sutures, and judicious use of diathermy. That's the best way. But whatever you do, whatever you say, you're bound to get flap necrosis in ileum block dissection. There's no doubt in it. In fact, any incision or the upper thigh is bound for necrosis, not just this incision. Okay. Okay, done. You are done well, really well. Thank you.
Thank you, Srinivas sir. Thank you, Saravanan sir.
Thank you, sir.
Kanna sir, thank you very much. Any other faculty would like to give comments, or can we call it a close, please?
If you do not have the facility for the frozen section with you, then what we have found is the imprint cytology is very good alternative for that.
Yes, sir. Yes,
Okay, if you have got the feature of the cytology, your pathologist is a good cytologist, he can tell you only on the imprint cytology. And that also gives you the idea about that. Yeah.
Thank you, sir. Thank you very much.
Okay. Okay, sir.
So,
Fine.
friends, we call this session a close. Shubham and Swapnil, thank you very much for joining us this evening. We look forward to meet all of you on the coming Friday. Thank you, faculty. Thank you, our faculty. Sahai sir, Jailal sir. Thank you very much.
Thank you.
Good night, sir.
Night, sir.